Hi, everybody, and everybody meaning two people. I'm Steve Poole. We haven't met before over this unusual format, and we're going to talk about Liber Chapter 11, which is cutaneous drug eruptions, which is a huge topic. I have had the misfortune of drawing this as my subject, and then you have the misfortune of having me try to explain it to you in an hour, which is totally unfair to everybody. But and I'm going to take the same approach I took about a month ago in the talk, and not attempt to cover the entire chapter, but go through some basic principles that are important, or that I think are important, and then a number of key patterns that you want to be able to recognize histologically. And so, as usual, I have the chat box open. If you have any questions, you can type them in there. I'm getting more skilled at this Zoom thing, I think, and I'll look in between cases or topics. So the picture I've got up, if you're not in Oregon, I don't know where the two guests are right now, but you've certainly read about fires here, and so the picture that's up right now is a view from my favorite spot on a normal day. I think this was back in July sometime, and with normal air quality. And then here's a picture from the same spot with the air quality index at about, I think, 320. So we were down to maybe a quarter mile of visibility, and indoors with masking tape over all the cracks in the doors, and a room air filter running 24 hours a day. So if you haven't had this experience, I hope you don't have to. It was a challenging week for all of us who had houses, not to mention the people that lost their houses, and that was a significant number of people. So so that's a little view of what's going on around here. So okay, so cutaneous drug eruptions and adverse manifestations of medications. I thought the first and most important thing was to review one of my old teachers, Philip McKee, who's now a very old Irishman. I was doing an online course that he was teaching recently, and one of his slides, he put up this information here about the minimal amount of clinical data that you should have before signing out a pathology report. And that this is both relevant to the chapter today and to every case. And if you look at this, and either you're a pathologist like Brian and I, or you're interested in pathology, how many times in the course of a week do you think you would get all of these: age and sex? Well, that comes through the EMR. Nature of lesions, probably not. Site, that comes. Symptoms, probably not. Duration, probably not. Clinical differential diagnosis, maybe, because that's a checkbox in EMA. Family history, never. And medications, I would say that the vast majority, I would say close to 100% of the cases that come rule out drug eruption somewhere in the clinical don't actually have the suspected drug. And
we see it.
So, sorry?
For the biologics, sometimes you'll see patient on Emerald or patient on...
True. It's very uncommon, though. I mean, most of the time. So, and the reason to mention this is that this is not important until it is. So we can all do our job reasonably well with a minimal amount of data. But it's the cases where you really need it, and maybe you don't know that you need it, that get us in trouble, both as pathologists and you as clinicians. And so I'm not advocating what Dr. McKee was in his talk, that every single case needs to have this, but I think the thing that gets lost these days in the pressure to produce, the increased burden of various aspects of practice, and the supposed efficiency of electronic records, is stopping on a case where you really need to stop and put more information. So if it's a 1 centimeter nodule, we don't need any more than that generally. If it's a 1 centimeter nodule and the patient has a history of cancer, yes, we absolutely need that. Not just to make the right diagnosis, but also to save the patient money and everyone time in chasing something that we don't know about. So I'm encouraging everyone who's listening or tuning in later to remember, as you get busier and life gets more complex, that there's some instances where you need to slow down and stop. And it's not just to help your pathologist, it's to help the overall situation. And one of my Mohs colleagues used to say, "Give your pathologist a chance," and I think that's a really good advice. Part of that history is I looked through, and there's quite a number of papers on this subject. Cutaneous adverse drug reactions are not always drug-induced. So this particular paper was talking about herbs and alternative medicine, and there's some figures that quote up to 40% of the population now uses what gets called complementary and alternative medicine, and those are unregulated substances by the FDA, and they're really important. So there are many times when I've called and said, is the patient on any medications? No. Is the patient on any herbal supplements or anything else? I'm not sure. So this needs to be part of the history. And here's a study that demonstrated that some homeopathic preparations, which, believe it or not, people still use and believe work, contain nickel, so some patients were having systemic contact dermatitis related to ingestion of nickel-containing substances. So there's a lot of stuff out there that we don't necessarily think about as MDs that are in things that people are ingesting. So many papers about this, and this can cause a wide variety of different types of drug eruptions, fixed drug, AGIP, DRESS, Stevens-Johnson, and this was a paper that found triggers that were in foods. I'm not sure what a xenobiotic is, actually, venoms. And so here's another one of my old teachers, Tim McAlmont at UCSF, who likes to say, the telephone is my favorite special stain. And that's the other thing that I think, especially in the last 10 years, people pick up the telephone less and less and think that communicating via the EMR is adequate. And I think a lot of key information on the select cases that need it can go missing using that system. So that his comment was really directed towards pathologists, but that I think could equally be directed towards clinicians. If something doesn't fit, pick up the phone. If there's a piece missing when you get the path report back, please pick up the phone and call us. It's often a piece of information that allows us to come to a better diagnosis, find something that we're missing, or learn something collectively. So, Brian, do you have anything to add to that?
Yeah, I mean, it's not all gloom and doom, because with Emma, you now have the ability to interface. So sometimes with some clinicians, we can actually look at the pictures and look at the clinical notes. And I found that really helpful in inflammatory dermatoses, where we could just go into. So
that's a good point. So if there is a detailed note, we can access it. Yeah. Okay, so then there's a number of general points, and these are probably the most important points for the day. And at the end of this page, you're going to think I'm just going in a circle, which this particular topic can lead you to feel like you're going in a circle. So the first general concept that everyone needs to remember if they're trying to learn pathology of drug eruptions is a single drug can basically cause any pathologic tissue reaction. And that includes, this is a fairly complete list of the tissue reaction patterns we see: exanthematous, urticarial, eczematous, psoriasiform, lichenoid or vacuolar interface dermatitis, bullous dermatitis, granulomatous inflammatory infiltrates, pustular infiltrates, and vasculitis. So drugs can give you just about anything. Conversely, a histologic pattern that you're seeing down the microscope can be caused by virtually any drug. Our ability to pinpoint specific drugs or rule out a drug eruption is very difficult because of that. But one of the things, number 3, is really important for those of you who might want to become pathologists. A combination of different tissue reaction patterns seen in the same slide is a fairly solid clue that you're dealing with a drug eruption. So if you see spongiatic dermatitis with a lot of apoptotic keratinocytes, the latter being a feature of lichenoid dermatitis, those two things don't really exist together in many of the idiopathic and well-defined dermatoses that we know and see on a regular basis. So combinations are a hint and sometimes a really solid clue that you're dealing with a drug eruption. And a few other points: the clinical for drug eruptions may differ dramatically from site to site. In particular, drug eruptions on the legs are often hemorrhagic and can look like they're vasculitis, even though they're not vasculitis, but they can be much more red and raised than they are on the trunk, even though it's the same process. So the morphology can be quite different from place to place. And then there are a number of clinical settings where your clinical question may not be able to be answered by a biopsy. And there's 2 that immediately came to mind for me, and we see this very often: bullous pemphigoid versus drug eruption. H&E is not something that resolves that. So bullous pemphigoid and bullous drug eruptions can have an identical histology on routine H&E stains. Direct immunofluorescence is the answer to that particular question. That doesn't mean that an H&E biopsy is useless, but it's not the answer by itself. And then contact dermatitis versus drug eruption, also a very common question. The number of drug eruptions that manifest histologically as spongiatic dermatitis are fairly low. and there's some debate over whether those are exacerbations of pre-existing atopic dermatitis induced by a drug or just a pure drug eruption. But that can also be a tricky thing where the biopsy may not give you the answer. Another thing that comes up frequently in evaluating these specimens is the temporal relationship. And we all know generally the drug eruptions appear in the skin from a day to a couple of weeks. What's maybe less known is that there can be a long delay of up to 2 years, patient on the same drug, no cutaneous problems, and then develops a cutaneous eruption that's later proven to be connected to that drug. And they may actually occasionally occur after cessation of the drug. So a long time course or not being on a drug anymore doesn't mean that what you're looking at is not a drug eruption.
Just two other things. In your questions asked, which we can't answer, two others that come to mind are the biologic versus psoriasis. And there's been a literature, I think, a couple of weeks ago on trying to distinguish these psoriasiform drug due to a biologic versus psoriasis in a patient on biologic for inflammatory bowel disease or something. And it's, on an individual cases, it's very difficult. Then the other one I can get is, lupus rule out drug, and there's all these drug-induced lupus, and the histology of those can't either sort out. So.
Yeah. Yeah. Thanks. Those are good points. I'm sure there's even more than that. And we'll come to the biologics towards the end of the talk. One of the other main points is people think, well, eosinophils are a marker of a drug reaction, and if they're absent, it's less likely to be a drug eruption. If they're present, it's more likely. Well, that's not actually the case. And going back to point one, that a drug can produce any pattern means just that. And one of the really interesting things is that DRESS, which has eosinophils as an essential part of its presentation, often doesn't have eosinophils in the skin. DRESS is actually a clinical diagnosis, not a pathologic diagnosis. And I thought this was interesting. Here's a paper about DRESS, and it says here, in the scoring system, skin biopsy suggesting DRESS gets assigned a certain number of points in their diagnostic scoring system. But then they go on to say the histopathologic features of patients with DRESS are generally non-specific. There's no single unique finding that can be used. So they're basically saying that the pathology doesn't matter when they said, well, here the pathology actually gives you a score. I think this statement is more correct, that the pathology for DRESS truly doesn't matter. And then the last kind of conceptual point is that a mechanistic approach of, is this allergic? Is this an extension of the intended action of the drug? Is this deposition? It's not particularly helpful. These things are so complex pathophysiologically. I mean, that's interesting scientifically to think about, but I don't think that really helps you much when you're trying to make a diagnosis and manage the patient. So, and actually, we think of these as allergic processes, but a minority of drug eruptions are actually allergic processes where the drug acts as a hapten and forms an antigen. So, so the most common pattern is a morbilliform or exanthematous drug eruption, similar clinical morphology to a viral exanthem. Again, may occur with virtually any drug. So you guys who are clinicians, you know this much better than I do, but here's the classical appearance, slightly closer up. And then this particular pattern also has a constellation of histologic findings, which are a hallmark of drug eruptions. So slight spongiosis, not generally dramatic spongiosis, some interface changes, so maybe some vacuoles, maybe some apoptotic keratinocytes, lymphocyte exocytosis, which means you have lymphocytes scattering up into the epidermis, parakeratosis if it's been around a little while and the epidermis has had time to react. You may not have that if it's very acute. Dermal edema, which is something you don't necessarily see in every other inflammatory process, so that's maybe a helpful feature. And then lymphocytes, eosinophils, maybe plasma cells. So let's look at one of these. CT20. Just look at the features 11012. Okay, so here's a morbilliform exanthematous drug eruption coming up. And if we look at medium power, you can immediately see that there's some papillary dermal edema here. There's some pallor. We know that this is mostly an acute process because the stratum corneum is normal basket weave. As described, there is spongiosis, so we've got widening of the intercellular spaces between keratinocytes with visible intercellular bridges. We also have apoptotic keratinocytes, so there's one with a condensed eosinophilic cytoplasm. I think there's some in even later stages with a crenellated hyperchromatic nucleus. We have lymphocyte exocytosis, so there are lymphocytes that have scattered up into the epidermis here. And then down in the dermis, we've got a mixture of lymphocytes, and I believe there are some eosinophils around here somewhere. Let's see if we can find one of those. Yeah, here's a number of eosinophils. So this is the typical characteristic morphology of a drug eruption. We even have that other finding here. There's the beginning of parakeratosis developing. And so features that are helpful here, if this were just an eczematous dermatitis like contact dermatitis, it would be very unusual, virtually unheard of to see this number of dying keratinocytes. It's not something that happens in the primary spongiotic dermatitis. So that's that combination of patterns I was talking about. So this is something really helpful to remember. Is it's got all the hallmarks of a drug eruption. I can't remember the clinical story on this particular patient, but that's a morbilliform drug eruption. So that's our prototypical case. I really like using prototypes and working off of that. And then for the rest of the time, we're going to look at a few specific examples. So instead of going through every aspect of Lieber and just regurgitating the textbook, or trying to cover it in exhaustive detail, which is impossible in an hour, I thought we'd look really at the diagnostic pathology and a few clinical pictures of a number of distinctive clinical pathologic entities. So we'll start with erythema multiforme. And here's the characteristic acral surface with target lesions with a dusky hemorrhagic center surrounded by a pale area and then an erythematous rim. And you all know the clinical better than I do, but the main systemic associations for erythema multiforme are infections, mainly herpes simplex virus and mycoplasma infections. And then a whole variety of drugs can produce this, the main ones being nonsteroidal anti-inflammatories, sulfonamides, and anti-epileptics, but the list is exhaustive, goes on and on. In a certain proportion of cases, there's mucosal involvement, which you see here with erosion of this poor person's virtually their entire lip. And then we'll look at the histology. The basics of erythema multiforme histology are, it's an acute interface dermatitis. And when I pull up the slides, we'll go into what that means. And some of the helpful features that might suggest a drug is causing this rather than infection are necrosis of acrosyringeal structures and potentially eosinophils. So let's go look at one of these cases. 1867. Okay, so here's a punch biopsy. This is a really beautiful case of erythema multiforme. When we talk about acute processes in the skin, or as I mentioned a couple of minutes ago, one of our hallmark features of an acute process is that it has a normal stratum corneum. So here's a normal stratum corneum, normal basket weave, normal thickness, no parakeratosis. That means that the insult to the skin has happened very recently. There hasn't been enough time for the epidermis to respond by proliferating, producing parakeratosis, doesn't have any serum. Then the other hallmark of acute interface dermatitis is lymphocyte-mediated keratinocyte necrosis. So here you're seeing a patchy infiltrative lymphocytes around the superficial vascular plexus that scatter up and abut and obscure the dermoepidermal junction and are associated with dying keratinocytes. Same features we saw before: brightly eosinophilic cytoplasm, crenellated or shrunken hyperchromatic nucleus, in this field right here, we actually see the full spectrum of, here's early EM over here, where you just have scattered cells at the junction. Here it's developing further, you're getting some apoptotic keratinocytes. Here it's developed to the point where you've got clusters of apoptotic keratinocytes, and this is incipient dermoepidermal separation. And then in the middle of the lesion, which I think corresponds to that darker red zone, here's where the epidermis is actually starting to separate. And I believe my second case has full epidermal necrosis, so we'll take a look at that. 685. So the late stage of EM 5 is when enough keratinocytes have undergone cell-mediated death. Oop. That's not the right number. Then the epidermis actually sloughs. No, I think I put the wrong number in, but I think that's you've got a good picture of that the end stage is just full thickness epidermal necrosis. So that's erythema multiforme. There's a detailed discussion I won't go into about Stevens-Johnson and toxic epidermal necrolysis, which have overlapping histologic features. The basic histologic process is the same: acute interface dermatitis with keratinocyte necrosis and some lymphocytes, and those are differing clinical entities, as you know, but there can be some overlap histologically. Brian, do you have any comments about EM?
No, again, often we ask to say, is it drug versus viral? And you really can't unless you see the follicular involvement. And then just going back to your morbilliform eruptions, I think erythrocyte extravasation can be helpful, because when you see a kind of spongiotic process with erythrocytes, drug versus virus is always more common than a primary eczema if it's not in a dependent lower leg area.
Yeah, thank you. That's a good point. Yeah. Okay, so we'll move on. The second major category I'd like to cover is lichenoid drug eruptions. So this is just going to sound like a recurring theme, because it is a recurring theme. So the kind of prototypical medications associated with this are quinacrine, gold. Does anyone get treated with gold anymore? Brian, do you know that?
I think for the biologics now for the arthritis, you know, they often.
Yeah, I think gold has gone out of favor, but NSAIDs, antihypertensives, but again, so these are the classics, but we see lichenoid drug eruptions that happen related to a whole variety of medications. So these clinical images are borrowed from DermNet New Zealand and a couple of other internet sources, but lichenoid papules with superficial scale, purple papules can look very similar to lichen planus, but different clinical distributions. And then the prototypical histologic features are very similar to lichen planus, but some of the helpful things that I've found are the presence of parakeratosis, apoptotic keratinocytes high in the epidermis, and plasma cells if you see them. I personally don't find eosinophils very helpful, because you can see eosinophils in ordinary lichen planus.
And especially hypertrophic.
Yeah, and especially hypertrophic. So EOs. Oh, and I'm just noticing. I'll come back to your question in a second. Sorry, I just looked at the chat box. Thank you. So we'll look at the histology of a lichenoid drug eruption, maybe two here. 15450. Okay, so I've got two examples of this. This one is a fairly muted version, but interesting histology. So there's a pretty sparse lymphocytic infiltrate. There are some vacuolar changes in basal keratinocytes. So we're thinking we're in the interface dermatitis category. There are quite a few apoptotic keratinocytes here, so that also matches with that. And then if you look, we're seeing them in the upper third of the epidermis, something you don't usually see in lichen planus. Your apoptotic cells are generally down towards the base of the epidermis in lichen planus. And here we're seeing parakeratosis. So those are helpful clues that this is a lichenoid drug eruption rather than lichen planus. And then there's a little bit more robust version, which we'll look at here. So this one at low power actually looks more like you would expect for hyperkeratosis, some hypergranulosis that you could push into a wedge-shaped category with some imagination, a more band-like lymphocytic infiltrate which obscures the dermo-epidermal junction. But this one also has apoptotic keratinocytes up in the upper epidermis. I believe there is some parakeratosis here somewhere. And I could not find a case. Here's a little bit of parakeratosis here. I couldn't find a case that had good plasma cells, so it's not super common, but when we see it, it's helpful. So lichenoid drug eruption, I think this one might be tricky if you have no history of drug, except for the high apoptotic keratinocytes. This looks very similar to lichen planus. So to go back to your question, NH. Sorry, I don't know anybody's name, but it's not so much follicular involvement, more common with viral than drug-induced erythema multiforme. I think that's your question, and you can unmute yourself. Oh, thank you. There you go. It's more that when you in EM, if you see necrosis involving acrosyringeal structures, then it's more likely to be drug-induced. And the proposed pathophysiology for that is that some drugs are excreted in the sweat duct system, and that maybe that's a site of immune attack because of that. So Brian, any comments about that?
Yeah, I mean, I think it's the acrosyringum that's supposed to be drugged, but in an individual case, it's very hard to come down, definitively. Yeah. A lot of these studies just look at probabilities and show that clinicals, a p-value, below 0.05. In an individual case, it becomes, you have to add in the plasma cells and the clinical.
Yeah. And I think there's actually a really sophisticated answer to your question. I don't know how much dermpath you know, but herpetic eruptions often have some overlap with erythema multiforme, and herpetic eruptions often involve the follicles. So it's not really, if you're looking at something that looks like our case of EM and you see follicular involvement, I don't think it's particularly helpful. But there are cases that are sort of overlapping herpes and EM where you see viral inclusions, and they very frequently have follicular involvement. So yeah, so good question, thanks. All right, so we'll move on. Fixed drug eruption. I think everybody's happy when they see something like this because it's a diagnosis that we can make. Beautiful clinical picture that's got the full spectrum, including late stage bullous area in this fixed drug eruption, beautiful targetoid lesion. Perfect color. Again, the prototypical associations are with Bactrim, tetracyclines, aspirin, NSAIDs, barbiturates. Does anyone get prescribed a barbiturate anymore? Reading through some of this is like, a lot of this is historical, but
it's how Lever.
yeah, exactly. So that's interesting. I mean, the other thing that stands out towards the end of the chapter is how many things are associated with NSAIDs. And oh, I've seen FD to barbiturates on the psych ward. Great.
Oh.
Well, that's fantastic. This is things pathologists don't know anymore because we're so removed from that. Thank you for that comment. So, and again, fixed drug, the more time passes, the longer the list is. So, and my take on fixed drug is this is not Lieber's take or Whedon's take, this is Steve's take, is fixed drug is like EM or TEM with melanophages and granulocytes. So it's generally an acute interface dermatitis, really similar to what we saw before. Here the stratum corneum is missing for some reason. But tons and tons of apoptotic keratinocytes to the point where you could see this whole epidermis necrosing and separating, which is what's happening in this part of the clinical picture. And a lymphocytic infiltrate, which abuts the epidermis, extends up into the epidermis. Since this is a picture from the web, I can't go to higher power, but there are a few eosinophils and neutrophils in here. So if you see an acute interface like this that also has granulocytes, the pathologist can actually say this is probably fixed drug eruption, or if the clinical's right, we'll just flat out say it's fixed drug eruption. So that's the classic combination. That's potentially a board's type question, acute interface with granulocytes. So that's always a satisfying diagnosis because we can say, oh, we know what that is, and generally that drug can get teased out. Brian, anything to add about that?
No, I mean the FDEs when they have the newts, and the other thing that can be quite useful is if you see the second insult with the same drug, you often will see melanophages and acute based on that. So.
Yeah, sorry, I'm leaving that out because that's a significant omission. So thanks for pointing that out. You generally see melanophages because this recurs in the same spot.
Yeah.
And melanophages are, if you don't know this aspect of histology, melanophages are often the product of basal keratinocyte damage, and their melanin gets released and is down in the dermis. So you'll see exactly this with a bunch of, there may be some melanophages down at the base of this one actually. So, okay, this is one of my favorite diagnoses. And despite mentioning the possibility of this, I'm not sure that I've seen a ton of cases where the clinical confirmed it. I wonder if these don't get biopsied that much because it's obvious that this is a drug eruption. But acute generalized exanthematous pustulosis, that's a mouthful. To say, here's the exanthematous part of that clinical picture here. Here's that plus the pustulosis part. So we've got little white raised areas corresponding to intraepidermal pus neutrophils, and the acute part may come with a high fever and leukocytosis, so it could mimic infection. Another really uncommon thing that might be in that clinical differential and the differential for the pathology is fulminant psoriasis. They can have that same fever leukocytosis. Most of these are drug-induced, and in this case, the prototypes are beta-lactams, macrolides, but many other drugs. And so the hallmarks of the pathology for AGEP are subcorneal pustules with adjacent spongiosis. So it looks like a combination of eczema and a pustular process. So let's take a look at an example of that. All right, so here we've got a shave biopsy for an inflammatory process. Interesting. A little bit of parakeratosis. We're off to the side here. There's some spongiosis. So again, spongiosis is widening of the intercellular space between keratinocytes. And once that happens, you can see these stretched intercellular bridges. That's the spines of the spinous layer. So that's spongiosis. We've got lymphocytes in the dermis. And then if you move over here, here's an intraepidermal collection of neutrophils, and there are also some eosinophils in here. And it's beneath a layer of parakeratosis, so we know that this is not just related to picking. This is part of the pathophysiologic process affecting this patient. So this is spongiotic dermatitis with subcorneal or intraepidermal pustules. That's the pathologic pattern, and eosinophils. This by itself would just get a comment with AGEP in the differential diagnosis. This could also be IgA pemphigus. With the eosinophils, pustular psoriasis would be less likely, but if you just have newts, this could also be pustular psoriasis. So there's some overlapping features that this histologic pattern is not specific for AGEP, but gets mentioned and in the right clinical setting, that's good for the diagnosis. So that's a typical picture for AGEP. Brian?
Right, this is AGEP. Sometimes you can see the suprabasal mitotic figures and the vascular changes of psoriasis, you know, instead of the spongiosis. So that helps you that way.
Yeah, good point. Good point. Okay, time is getting on. So we'll do one quick thing that's it's not really a drug eruption in the way we've been thinking about drug eruptions, but let's talk about minocycline. I'm sure this is a board exam question. I know there's historically been different types of minosin pigmentation, and I think this is still relevant, but there is some overlap between them. So there's blue-black pigmentation in areas of scarring or inflammation, especially on the face, that is actually hemosiderin on the microscope. Blue-gray pigmentation in previously normal skin, especially on the legs and arms, which is a pigment that stains with both Fontana Masson stain and a Pearls iron stain. So there's no natural substance that stains with both of those stains. So that's actually drug pigmentation. There's a diffuse muddy brown pigmentation in sun-exposed areas that corresponds to increased basilar melanin and melanophages. And then there's also can be nail and scleral pigmentation. So here's the shin type, and then this is nice and blue-gray. And so the histology of this is pretty characteristic. So look, we've got a normal epidermis up here. We've got pigment in here that's something between brown and black to my eye. So it's not refractile and golden brown, which are the words that I associate with hemosiderin. It's not globular and brown, which are the words that I associate with melanin. It's a black-brown, which doesn't really look like anything that we normally see in the skin. It's not black like we see with tattoos, carbon pigment. So this is suspicious that this is minicin on H&E. Here's a Pearl's iron stain, which stains iron or hemosiderin blue, but it also stains minicin pigment. So the same cells staining with the Pearl's iron. And here's a Fontana-Masson stain, which you can see the internal control is staining the melanin and the basal layer black, and it's also staining the same group of cells. So overlapping staining with Pearl's iron and Fontana-Masson is not specific for minocycline. It can be seen with a wide variety of drugs that can deposit their pigments in the skin, but it's very characteristic of a non-physiologic pigment. So that's a great case. We just recently had a patient who has had multiple biopsies and pigmentation on her face, and the biopsies show a picture very similar to this, but she's on a couple of drugs, none of which are currently on the list for producing drug-induced pigmentation. And so that clinician is really bedeviled by what might be causing this. And again, that's the more time that passes, the more drugs that get put on the list. Brian?
Yeah, I mean, just they used to love type 1, 2, and 3, but I think there's more overlap than we like. You know, it always seems so clean, but it's not.
Yeah. Yeah, it's actually. I mean, it's a point. I'd actually forgotten the number 3, the increased basilar melanin and melanophages that can be associated with minicin. And when that's important to remember when that question comes up, that you could see something that just looks like increased normal pigment that can be related to minicin, even though it's not the drug itself.
Like melasma on the face, you know. And,
yeah. So then the last 2 things we'll talk about are newish and new classes of medications. So anti-TNF medications, which I think they're only new if you're somebody Brian's or my age, because we can remember a time when they didn't exist. And what's that?
tar and dithronol.
Yeah, exactly. So these are obviously in widespread use for a lot of different things, clinically really important, and something that comes up in dermatology. I don't feel like we see a ton of biopsies related to this, but the clinicians are certainly seeing these. And here's a large series of IBD patients, and it was almost 30% of them had a dermatologic complication, the most common was infection, which you would expect, injection or infusion site reactions, but then 5.3% have these psoriasiform lesions, which this was exciting when this first came out because it was a new thing in derm and dermatopathology. And since some patients with psoriasis are getting treated with these, there was a question of, is this psoriasis? Hello? Nope. Sorry, I just heard a strange sound. So here's the clinical of one of these eruptions. So there's an irregular plaque on acral surfaces, erythematous acral surface. And so these are common. What's the pathology of these? Well, again, broken record. There's a histopathologic spectrum, which shows, as you would expect, psoriasis-like pattern in established plaques, pustular psoriasis-like findings. Some patients that had an interface or lichenoid dermatitis mimicking lichen planus, pustular folliculitis, and eosinophils from none to numerous. So there you go again. These psoriasiform eruptions in TNF blocker therapy can have many different patterns down the microscope, and like the lists of drugs have grown, as time has passed, initially people thought, oh, these look like psoriasis, or there's some version of a pustular dermatitis with lots of newts and maybe psoriasiform epidermal hyperplasia. Well, now we know that these TNF blockers can give you virtually any pattern. So the psoriasiform pattern, I think, is still the most common. So now newer medications, these seem really new to Brian and me. Probably not new to you guys in training, but so targeted therapy. So BRAF, about half of melanomas have BRAF mutations. BRAF is an oncogene. So in the conceptualization of cancer being related to accelerators that are stuck on or brakes that are stuck off, this is the accelerator stuck on. So melanomas with BRAF mutations get treated with BRAF inhibitors. And surprise, surprise, there's a wide variety of cutaneous side effects to BRAF inhibitors that include rashes in a very high percentage, 2/3 to 3/4 of patients, non-specific rashes, but then also proliferative lesions. So verrucous lesions, warts, and keratoacanthomas, sometimes eruptive keratoacanthomas and squamous cells in about 25%. That's pretty interesting. And so these are real things, since this treatment has now become fairly common. And I don't have much on the histology of this, because this is the histology of these are the rashes. There's really no specific findings, and the other things look like the other things in other patients, like KAs look like KAs. So then checkpoint inhibitors, which are kind of the removing the brake on the immune system aspect of cancer therapy. Current major ones are anti-CTLA4, anti-PD1, and anti-PD-L1. And to complete the lecture back where we started, checkpoint inhibitors can cause eczematous eruptions. They can cause lichenoid eruptions. They can cause psoriasiform eruptions. And then I thought this was really interesting for the real pathology freaks out there. This is kind of the latest and greatest, and I wasn't aware of this until fairly recently, but checkpoint inhibitors can cause granulomatous reactions. And this is interesting for a couple of reasons. This seems to be an extension of the natural action of this medication. So, completely different than an allergic type reaction. And this can cause the whole spectrum of can you still hear me?
Yeah.
Okay, I just lost one of my screens for some reason. I had something strange happen. So these can produce sarcoidal type eruptions, GA type eruptions, granulomatous paniculitis, and one of the things that comes up is that these granulomatous infiltrates can be very nodular and raise the consideration of, is this tumor recurrence? And so they get biopsied. So, and I'm sure that that's a real cause of patient anxiety. So again, to sum up, we're back where we started. Any drug can produce virtually any pattern. Any pattern can be associated with virtually any drug. And as new drugs are developed over time, we're going to see this cycle repeat itself. So, so it's 5 o'clock. That seems like a good place to wrap up. I know we just touched on this chapter. It's a huge chapter. We could probably give 4 lectures on drug eruptions. Brian, do you have anything else to add?
Just for the boards, I mean, sometimes a drug eruption is good. So in EGFR inhibitors, the follicular pustules or pustular folliculitis indicates the drug is working. That's a kind of interesting drug. And then I've seen things get repeatedly called actinic keratoses, and these are antineoplastic drugs where you get epidermal dysmaturation. So that's can sometimes help the clinician, you know, in a patient on chemotherapies and stuff, and they have this dysmaturation in the epidermis. So,
yeah, that's a whole other thing I chose to skip over, but okay, thanks everybody for coming. If you're watching this on video, I hope this was helpful, and thanks for the questions. Though those are, it's always great to get questions and get our minds working. So appreciate everybody coming. Have a good rest of your Sunday, and we'll see you next time.